Assalamu alaikum. The difficulty with decisions in the management of Globus Pharyngeus is that the etiology is not certain, the possible pathology are diverse, there is no gold standard test for diagnosis, and the condition is very common. In this presentation, we'll go through a pragmatic approach to the management of Globus Pharyngeus. About a dozen or so of different disorders may present initially with just globus. Things ranging from hypertrophy of the base of the tongue, pharyngeal inflammation or irritation by various agents, pharyngeal irritation by a retroverted epiglottis or a hypertrophied cervical osteophytes, thyroid nodules or after thyroid surgery, phonoathenia and associated neck muscles tension, iron deficiency anemia and Plummer-Vinson syndrome, the very rare but well documented possibility of having an occult malignancy in the upper aerodigestive tract, and the more common causes of laryngo-pharyngeal reflux or oesophageal or pharyngeal dysmotility and upper oesophageal sphincter hypertonicity. So all these groups of patients may present initially with globus, and there must be a pragmatic step-by-step approach to identify these groups, the high risk, the common, and those who can be simply managed in a very orderly manner. In a well-quoted survey about the way ENT specialists in the UK deal with Globus Pharyngeus patients, the results showed that 86% of the patients had one sort of investigation. Some of these were invasive. About two-thirds of the patients had rigid endoscopy with all the associated risks. More than half of the patients had a barium swallow, and about 17% had a combination of the two methods. We'll go through the different ways of assessing and investigating Globus Pharyngeus patients, starting with the flexible Larngo-Pharyngoscopy as an outpatient procedure that is safe, effective, and rapid, and it can show if there is any structural cause for the globus sensation, any masses, ulcers, any irritation to the pharynx, retroverted epiglottis, osteophytes, pooling of saliva, things like this. Adding a dyed foot or colored foot like a kiwi fruit to the flexible laryngoscopy would add more information about the functional aspects of the pharyngeal phase of swallowing. It will show if there is any pharyngeal residue in vallecula or the piriform fossa, any laryngeal penetration, any aspiration, and transient time in the pharynx, and other important aspects of the swallowing. In the UK survey I just referred to, more than half of the globus patients had a barium swallow. Barium swallow is quite specific, 97.5%. So if there is a structural cause, it will show it, like a pharyngeal pouch or stricture or stenosis or a mass. But the problem with the barium swallow in globus patients is that the very high rate of false positive cases. It would suggest that there is an abnormality or a lesion, and in further investigations by rigid endoscopy, which is invasive and somewhat risky, it would turn out to be normal. And in fact, in a recent report, the cases that have been suggested to have a tumor by the barium swallow, all of them turned out to be normal. A barium swallow is not going to show a tumor that you cannot see by flexible endoscopy either in the pharynx or the esophagus. Also, barium swallow in patients, in globus patients below the age of 30 were always normal, so there is no much point of altering a barium swallow below that age. Barium swallow had in fact identified problems, lesions in the lower esophagus in globus patients who have also reflux disease, at least 1/3 of the patients with a globus initial presentation would have problems in the lower esophagus, as demonstrated by a barium swallow. Another technique that was used in the assessment of globus pharyngeus patients is video fluoroscopy, which would add some more information about the functional aspect of pharyngeal swallowing and how the pharynx and the larynx deal with a bolus. A video fluoroscopy in globus patients would show abnormalities in as much as a quarter of the patients, but these abnormalities are rather unspecific. Things like retention of dye in the vallecula or sometimes in the piriform fossae, or failure of pharyngeal elevation, a very non-specific type of abnormalities, not much higher than the normal population. The only abnormality of note that is significantly higher than the normal population is a higher incidence of laryngeal penetration. But the routine use of video fluoroscopy is not of much help. Rigid endoscopy is best used for assessment of the blind spot in the flexible examination, the area in the postcricoid, the upper esophagus, and the apices of the piriform fossa. This can be visualized better with a rigid endoscopy. On the other hand, there is a 1% risk of serious morbidity. Another technique that was used in the assessment of the globus pharyngeus patients is the intraluminal manometry that would quantify the timing and the pressure gradients in various segments of the pharynx and the esophagus. And it was used to explore if there is any significant differences between globus patients and the normal populations, things like upper oesophageal sphincter pressure and timing of relaxation and things of the sort. It did actually show abnormalities in as much as 2/3 of the globus patients, but these abnormalities again were very non-specific, and it could not demonstrate or confirm the association between globus sensation and an elevated upper oesophageal sphincter pressure or relaxation time or pharyngeal transient time and things of the sort. So it did show lots of different non-specific abnormalities. None of them was diagnostic. The use of flexible transnasal oesophagoscopy in globus patients as an outpatient procedure was a game changer. Some of the cases were aborted because of inability to pass the scope, or the patients could not tolerate it well, but it did show significant abnormalities in the lower part of the esophagus in somewhere between 1/3 or half of the cases of globus patients. Things like oesophagitis, hiatus hernia, Barrett's metaplasia, candida infection, strictures, or even tumors in about 4% of the cases. So it was quite useful. So to sum up, the techniques that are of limited diagnostic value in the management of globus pharyngeus patients are things like psychological assessment, manometry, a barium swallow, CT or an MRI scan of the pharynx, rigid endoscopy without red flag signs, and check biopsies from areas that look apparently normal. On the other hand, the use of a patient scoring system like the Glasgow Edinburgh throat scale is quite useful, not only to mark the baseline for patients with globus. It will show that they score high in things like discomfort in the throat or clearing of the throat by coughing or frequent swallowing, and it will also show that they score very low in things like dysphagia, pain in the throat, and throat closing up or throat swelling. So it will mark the baseline, and it will also be helpful in the follow-up to see how these patients progress by various forms of management. The other essential thing at the first consultation of Globus patients is to identify any of the red flags. Things like weight loss, dysphagia, pain in the throat, voice changes, otalgia, symptoms related to one side of the neck rather than in the midline, or if the patients had risk factors for developing a tumor, like smoking, alcohol excess, if they are elderly or had previous head and neck tumor, regurgitation of undigested food, systemic symptoms like fever, night sweating, and abnormalities in the examination like any suspicion of lymphadenopathy or any ulcers or masses. The risk of having an occult malignancy in Globus patients is quite low. There are few reports that actually show that the incidence is less than 2%. Now, the empirical management plan. In the very first consultation with the Globus Pharyngeus patients, you will get to fill up the Glasgow Edinburgh scale to mark up their baseline. And they will also be checked against all the red signs. All patients may have a flexible Larngo-Pharyngoscopy because it is safe and effective, and it will show up almost all of the abnormalities in the oral cavity, oropharynx, or the hypopharynx, plus of course a neck examination. And then almost all patients may be referred for a flexible trans-nasal oesophagoscopy, which would demonstrate if they have any lower oesophageal abnormalities. You would expect that at least a third of the Globus patients have a lower oesophageal abnormalities. Up to half of them would have things like oesophagitis and ulcers and strictures or a Barrett, so on. And then consideration would be given to whether the patient requires a rigid endoscopy, which is risky and invasive, and it should be saved only for the high-risk patients above a certain age, or if they are smokers or have history of weight loss or other red flags. And then empirically, you would consider whether the patient may benefit from a course of proton pump inhibitors for 3 months, or an statin mouthwash, a low dose of Amitriptyline, or voice therapy for selected cases. And then the question of follow-up. And some of the intermediate groups may need to be seen in 3 to 6 months. The mild and straightforward cases may be discharged after reassurance, and the high-risk patients would require rigid endoscopy. About 2/3 of the Globus patients as a group may have either symptoms or signs of one or the other forms of reflux conditions. And that's the basis of the empirical use of proton pump inhibitors for maybe 3 months or so. If the patient has the symptoms of reflux and these symptoms are of short duration, then he is much more likely to benefit from proton pump inhibitors. If the patient has laryngo-pharyngeal reflux symptoms, then the treatment should extend to more than 3 months, up to 9 months sometimes, on twice daily doses of proton pump inhibitors, and also combined with liquid alginate. If the patient don't have any reflux symptoms, then it's unlikely that the proton pump inhibitors would be of much benefit, and a trial had showed that the benefit of the proton pump inhibitors were very similar to a placebo. Consideration should also be given to providing the patients with amitriptyline. In a randomized controlled trial, it was shown that the amitriptyline given once daily before bedtime would be well tolerated in a low dose like 25 milligrams and can significantly improve the patient's symptoms and quality of life and the sleep compared to the effect of proton pump inhibitors. Another randomized controlled trial and demonstrated that adding liquid alginate suspension to proton pump inhibitors would improve its effect significantly. The liquid alginate should be given in suspension form, 10 milliliters 4 times a day before meals and at bedtime. Another form of treatment to be considered is voice therapy to reduce laryngo-pharyngeal tension with neck and shoulder exercises and relaxation techniques. A randomized controlled trial had shown that for patients who had received the voice exercises and voice therapy had significant improvement of their globus sensation compared to the control group. So to sum up this empirical management plan for the Globus Pharyngeus patients, there is an obvious need to identify early those patients who have high risk with red flag signs. And these patients would need to be managed differently with further investigations, mostly with rigid endoscopy plus or minus biopsies. The vast majority of the remaining patients would have one or the other form of reflux conditions, be it gastroesophageal reflux disease or laryngo-pharyngeal reflux or non-acid reflux. And for those patients, it may be helpful to start them on an empirical treatment plan of proton pump inhibitors plus liquid alginate and diet modification. And the vast majority would improve and have their symptoms resolved within 3 months, and then you may just want to titrate the treatment dosage. If there is improvement in their symptoms, but they still have residual problems, you may change the proton pump inhibitors, or you may increase the dosage and extend the treatment period. For the small group of patients, the remaining patients, who would not respond to the empirical treatment of proton pump inhibitors and the liquid alginate, you may consider other options of investigation like video fluoroscopy or manometry or maybe other forms of imaging, or you may consider having other forms of treatment like adding amitriptyline or voice therapy to the standard dosage of the proton pump inhibitors and the alginate. By this, we come to the end of this presentation on the pragmatic approach to the management of Globus Pharyngeus patients. Assalamu alaikum.